So let's look at the prevalence of pelvic floor dysfunction. 1 out of 4 people do have some sort of pelvic floor disorder. And urinary incontinence affects 60 to 70% of women over the age of 65. Those numbers will vary though, because it first has to be something that they're going to admit, right? Same thing goes with pelvic organ prolapse. I've seen numbers anywhere from 20 to 70% because some organ prolapses are asymptomatic. People in pain though, they're more likely to report it because they're motivated to do so. And it's not just deconditioned people that have issues in this area. Even elite female athletes will have some problems. Sometimes it's not just a loose hammock, sometimes it's really high tone, and they can have similar things like urinary incontinence. So several studies show that among fitness instructors, there's actually a higher rate of pelvic floor dysfunction. And it's not just women, men also can have issues like erectile dysfunction, prostate problems, low back pain, etc. And here it shows that 2 million outpatients every year in the United States are for male pelvic pain. And approximately 11% of those are visits to a primary care physician for pelvic floor dysfunction. So men, kind of conservative estimates, because, you know, first you got to be willing to admit that you have a problem. And some of these things aren't what you want to really share unless, you know, you're having a lot of pain, and then you're, like I said, then you're motivated to do so. So it's not just women and men. I mean, just older people either. Everyone has a pelvic floor. I mean, children have a pelvic floor. We could even incorporate something into when we're piping children to prevent dysfunction, so that they're aware of these muscles and what they do to help our body. So yeah, looks like 50% of men in nursing homes experience urinary incontinence, and 18% of community dwelling men will experience urinary incontinence as well. I'm just going to turn off my picture here, picture, so you can look at my screen better. Okay, so 90% of primary care providers do not refer out for urinary incontinence. Most primary care physicians do not screen for pelvic organ prolapse, and more than half believe that pelvic organ prolapse, that it's rare, right? So we have this problem with our physicians, and, you know, like, what are they doing? Are they being told, you know, women that, oh, honey, you're just getting older, right? No, that's not acceptable. And then the other thing is that they put you on the pharmaceuticals as a first step, which is not recommended in the literature at all. So why don't doctors, like, you know, even OBGYN or midwives maybe screen for this as part of their general care as a preventative measure? But usually they wait until you complain about it, until you say that you feel pressure, right? Or you're having some leakage or urinary incontinence, or maybe urgency issues, or, you know, until you feel like something's falling out of you, and then they address it. And a lot of times by that time, if something's falling out of you, it's too late. There's no amount of exercise that can fix pelvic organ prolapse. So we need to start catching this earlier. We need to demand maybe better care at a pelvic exam. If they don't know how, then that might motivate them to learn. We see also here that 71% of women are unaware that a vaginal delivery in childbirth increases the risk of pelvic floor dysfunction. which was kind of crazy to me. I used to think, you know, that it was just an issue about having babies, and that's when we had to learn our Kegels and that kind of thing. And it shows that 71% aren't even aware that that can increase the risk of pelvic floor disorders. So we're not even doing a very good job there. And that's supposed to be more common knowledge. So, I mean, that study was done in 2011. Women reporting prior knowledge of pelvic floor muscle exercises may still perform them incorrectly. So even when they are given Kegels, 24 to 70% have found to be doing it incorrectly when they measure that with a vaginal examination. Right? So, you know, imagine an area of your body that you can't even see, and add to that maybe some layers of taboo over it. Maybe someone told them that they should never touch or look or go into that area. And so your brain doesn't even have a good map of that area. So are we surprised that they don't get it after a one-time handout and a one-time explanation? So exercises that they give aren't even individualized, right? So there's a lot more to offer than just Kegels. Put this up, right? So I just wanted you to see me because I'm thinking, you know, we don't do this with any other area of our body, right? So like if you're having pelvic floor issues and they hand you Kegels, I'm thinking, well, what if I had a problem with my arm? Are you going to just hand somebody a dumbbell and say, just keep squeezing? That's all you need to do, is just keep squeezing and building up muscle in an arm? No? Yeah, I don't think so. Like, you know, sometimes muscles are too tight, right? Massage therapists know this. They get tight and contracted and they might need some relaxing, maybe even a manual pull down, but you know, massage therapists can't do that, but we can recognize the dysfunction, and I'll be explaining that as we go along, the different signs of that. But sometimes we need a little stretching, a little lengthening. And you know, somebody called you on the phone and said they had a shoulder issue. How well would you, without having seen them or palpated or anything else, be able to recommend some exercises for that shoulder, right? I mean, better assessment of what's going on. If somebody's too tight, it could make things worse if we give them Kegels. So we really need to not be so shy and reach out to our healthcare providers or a physical therapist that specializes in pelvic floor dysfunction would be a good place to go. And, you know, just the studies show that if we can provide some instruction and getting feedback that's associated with the correct and effectiveness to control symptoms of the pelvic floor disorders. Okay, and so it looks like race and education and income seem to make a difference. And so here we see that compared to white women, African American and other women of color were nearly 3 times as likely to lack knowledge about the well-established detrimental effects of vaginal delivery on the pelvic floor support and continence, and that exercises can help control leakage of treatment options for urinary incontinence and pelvic organ prolapse, and that the prevalence of incontinence decreases as education and income increases, right? So that's where, you know, if we can get some resources for them and, you know, we might be able to prevent some of this stuff, right? I'm going to turn this off again. So let's see. 94% of women believe that there is no help for pelvic floor dysfunction and that it's just part of getting older. And doctors aren't really talking about it to patients or screening for it or explaining the risks involved. Yeah. Inadequate knowledge about pelvic floor disorders and available treatment options plays a major role in the limited care seeking behaviors of women with pelvic floor disorders. And so some of these pelvic pain and disorders aren't very well understood. So even when they have symptoms and they see somebody, it can take a while to find the problem. Going through lots of painful tests, biopsies, x-rays, MRIs, and sometimes these tests can come back negative, right? And then you don't know why. And then maybe they guess. And maybe they just generally categorize it. Or they prescribe drugs that don't fix the problem and leave you with answers like, there's no reason for your pain. So, you know, some pelvic floor disorders are not very well understood, and studies show that it can take 5 to 7 years and more than 5 physicians to get an accurate diagnosis or a treatment plan for people with chronic pelvic pain. It's not until somebody says, hey, what about the musculoskeletal system, right? And then we finally get to the root, right? And then you add to that, you know, some people get really embarrassed, and, you know, they can even, here it says 65, that's 2/3 of all women in this study couldn't find basic female anatomy, right? They had the problem using the words vagina or vulva, and when asked to identify it on a chart, they couldn't. 65% of women didn't know. They were calling the vagina the vulva and were really confused to find out that wasn't what it was. Another study said that nearly 40% of 16 to 25-year-olds use code names like lady parts or women bits or the vajayjay, the hoo-hoo, right? It's kind of funny, but it's funny if you know the name and then you're using that, but if you don't know, I don't know. So if people do get embarrassed about it and you're one of the professionals that works in this field, like a physical therapist, you know, sometimes you might need to use some different tools or imagery to help clients so they don't get embarrassed when identifying some of these parts. And under each slide, when you get that in your email, it will have all the studies that I'm referring to, and you can do a little bit more research on that if you want to. So biofeedback is shown to be helpful. There are these electronic devices that go internally. A lot are made for women and they go in vaginally, but there are some that go in rectally for men. And physical therapists have professional devices at their office. But if you're embarrassed, and like I was saying before, there's some of these things are like little Fitbits, right? And they help you to move more, and you can have an app on your phone, and they get notifications, which is most important because it can remind you to do exercises. So when we have a weak pelvic floor, this will help it be stronger. And it shows that when used in combination with pelvic floor muscle exercises, when you're going through a program, if you're using this device at home in combination with that, it was 30% were improving in the study more so than the ones who weren't. So it is something that you can do, but they're not foolproof, and it really is better to get an assessment in person. So some women, when they're doing the exercise, their muscles actually push down rather than pull up, and they don't notice it. And so some of these devices could give a false positive and reinforce bad habits. So like I said, they're not foolproof, and it takes some work to figure out how to do the contraction properly. And we don't want to squeeze the wrong muscles and get positive results. So don't forget your physical therapy. But also, if you're recovering from having a baby or you had a diagnosed pelvic floor issue, then seeing a physical therapist would be your best bet. And you want to make sure you're starting off on the right foot. And also look for FDA approval, because some of the devices out there, you know, they need to go through an FDA approval process so we know that they're effective, and yeah, you're not getting ripped off or getting hurt with some things. So, all right. All right, so screening in our scope of practice professions might have some of these questions on your intake form about our bowel and bladder function, maybe, as massage therapists. Certainly if they have low back pain or pelvic pain, but we don't generally have genital pain or intercourse pain on our intake forms, but a physical therapist might. But these were, if you work in the field, and then these would be some of the things you want to have on your intake form. If they've ever had an abdominal pelvic surgery or bladder or kidney infections, if they have pelvic inflammation or any kind of GI distress. When they're getting an exam, do they have pain with that? Do they say anything? Do they have low back pain that's not going away no matter how many massages they're getting and stretching and exercises that they're doing to strengthen or relaxing the area, whatever they need, and it's still not getting better? It might be pelvic floor. Post-void dribble. You think you're all done, and then it keeps coming, right? Men might have erectile dysfunction, pain during either sex, pain during or after climax, a history of physical or sexual abuse, or trauma. That could be a birth. Birth can be pretty traumatic, and sometimes you think having a baby has a loose hammock hanging down, but it goes way up, so it never would happen again. And so they might have too high of a tone. So we'll be talking about high tone and low tone and whether this is in your scope of practice or not. I mean, maybe somebody's coming to get a massage and they want to go to the bathroom prior to their session just in case. Or maybe you go to the bathroom between each client just in case, because you don't want to stop in the middle of your massage to have to go to the bathroom. Or maybe you don't have any warning and then all of a sudden you have to go, right? And like you didn't have any signal, and then all of a sudden it's like you can't even make it there. You're going to pee in your pants, or maybe you do, right? Or maybe you just went and you feel like your bladder's empty and you have to go again like 20 minutes later. So we'll talk about like what is normal and what's not normal and all that kind of stuff. And sometimes those muscles are completely healthy, but they're being conditioned in a bad way. And then you're getting incorrect signals, right? If you're not waiting for your bladder to completely fill up before you void, then it might have a signal to want to void sooner than, you know, it thinks it's full, but it's really not. So there's a lot to it. This is just the tip of it. I'm going to be going over all the muscles and all that. I just want to give you, you know, like the onion and breaking it all apart here down to different layers. So these are some of the red flags, so that if you're a physical therapist, then this isn't somebody you'd normally work with. You'd want to refer to the appropriate physician that specializes in these things. But I think it's good for, you know, things come up in conversation when people are getting a massage or they're doing exercises, maybe not related to pelvic floor, and you might see some of these and be able to refer out to the appropriate person and get them some help. So the hematuria or persistent abnormal bleeding, the hematuria is the presence of blood in a person's urine, and you have a persistent urinary tract infection, any gastrointestinal changes, reduced renal function or kidneys, saddle anesthesia, which is the loss of sensation, restricted in that area of like your buttocks, your perineum, and the inner surfaces of the thighs, recent pelvic surgery. Have you had symptoms that are getting more and more severe over time, not going away? Maybe there's a fall discharge, undiagnosed dermatologic changes in your perineum, incontinence without a urinary tract infection in young adults. That's not normal. Overflow incontinence. That's a form of urinary incontinence, which is characterized by the involuntary release of urine from an overfull urinary bladder, often in the absence of any urge, like I was just talking about. You know, you don't have any urge to go, and then all of a sudden it starts coming out, but you never had a signal to go. So that can also, though we'll talk about medications, but that can sometimes be a side effect from certain medications, and it can be from marijuana too, which is all the thing too. That might be another workshop coming up. So just so you know, weight loss, change in prostate. You know, some of these things could be indicative of cancer. Poor urine output. That's another one. Appetite changes, severe fatigue, fever, your way of you think changes, cognition changes, or stool changes. Are you having constipation or diarrhea? Okay. So referring to others, these are certain professionals that we would look to refer out to if we hear our clients talking about these things. Urinary symptoms, you would go to a urologist, or bowel systems to a gastroenterology. Pelvic organ prolapse, a urogynecologist. Pelvic pain could be a physician, a urologist, urogynecology, or a gynecologist, could any of those. If they're established, maybe go to the one that would be already, you know, you're established with to start with. And then there's some things here to refer to for pelvic physical therapy, the APTA section on women's health. Although women's health is kind of a misnomer, it's not just women or women who are old or postnatal, but athletes, men, like I was saying. And there's also another professional directory where you can find a physical therapist on here with the hermanwallace.com. And don't forget, this area of the pelvic floor comes with a lot of feelings and emotions and thoughts and beliefs. And we might want to involve some counselors or social workers or behavioral health people, right? And maybe the counselors need to be educated on pelvic floor dysfunction as well. Also recognize that constipation is a side effect of some psychotropic medications, and that can affect the pelvic floor. And we might want to seek out some Pilates or yoga therapists that are in the know, right? So yoga therapists are different than yoga instructors. They are trained to work with people who have medical issues. So we need a team. It takes a village sometimes. Okay. So this will take us to our first lab, where it's called the Pelvic Clock exercise. And what you might want to do is get yourself a rolled up towel if you want to pause this, and you're going to place this right down below and sit on it, right? So it's right there down the center in your perineum. And we're going to take a look at this clock here. I'm going to turn myself off now as I do these exercises, and I'm going to have a video afterward. Okay, so look at your clock here, and you can see the pelvis, right? So you see where the pubic symphysis and the writing, identifying the parts, ignore that. We don't need to do that. But if you're taking this course, then you should know where that area is. And anyway, this is also a great exercise for people who get embarrassed or not really sure where their pelvic floor is to get started. And but you want something that's pressing up. You could use a stability ball and give yourself some room. All right. We don't want to sit right on the back of the chair. And the rolled up towel is just for a little increased proprioception or tactile awareness in this area. And how thick of a towel just really depends on how squishy the seat is, or, you know, how sit on it, see how it feels. You just want some pressure to feel. You definitely wouldn't want to do this sitting on a toilet. You wouldn't feel anything. And like an exercise ball, stability ball, that'll press up against the pelvic floor as well. So with this exercise, what we're going to do is we're going to go ahead and tilt our hips towards 12 o'clock. That would be our pubic symphysis, right? So you can feel for your bony landmarks and do an anterior tilt, right? And that's our 12 o'clock. And then posterior for the number 6 o'clock is our coccyx, right? You can feel for that bony landmark as well if you need to. You'll be able to feel that. And then the 3 and 9, kind of side to side, rock side to side. Those are our ischial spines, yeah, our sit bones, right? So we're going to basically tilt the clock forward to 12 is another way to do this, and then come back to neutral and relax. Then let's go to 1 o'clock, slight change, back to neutral, to 2 o'clock, and back to neutral. Let's go to 3 o'clock, right? Back to neutral. Or we could reverse, right? So we could go to 11 o'clock and back to neutral, to 10 o'clock, back to neutral, 9 o'clock, back to neutral. And we go to 6 o'clock, back to neutral, to 5 o'clock, back to neutral, to 4 o'clock, back to neutral. Let's go to 7 o'clock, back to neutral, 8 o'clock, back to neutral, 9 o'clock, and back to neutral. All right, so we want to repeat these clockwise, counterclockwise. We can go all the way around, and then we can go backwards all the way around. And just repeat across 1 or 2 hours to improve the proprioception. Okay? I don't mean 1 or 2 hours of your time, 1 or 2 hours around the clock here on your clock. So the option to start with larger movements and then gradually decrease the size to improve awareness and control. So another image would be to use a pelvic bowl. And yeah, so like we could tilt the bowl forward and spill a little water and then tilt it back. And we just want to wake up the whole area. And we never had to say bulbospongiosis, which is where we're headed next. But I want to play you a short video of me holding the pelvis model.
So doing the pelvic tilt is sometimes hard to explain to somebody. Sometimes I'll use my pelvis here to give an illustration that A anterior tilt is when we're going forward or anterior, or we can think of the bowl as we're spilling a little bit of water out of the bowl forward, and posterior tilt would be coming back and dumping a little bit of water to the back side. So if we're looking at the pelvis can go all different directions when we're talking about a pelvic clock. Our 12 o'clock would be coming forward or tipping water out of the front of the bowl, and our 6 o'clock would be coming back to 6 o'clock or posterior tilt, and our 3 and 9 would be moving side to side. We're trying to touch these processes, the ischial tuberosities, into the chair or ball, side to side, without moving your whole spine, just your pelvis. So the pelvic floor has both superficial and deep muscles. The deep ones would be inside, so when you go this direction, you can see all the musculature in there, versus the superficial would be everything you see on the outside. And the perineum would be the tissue right in between. So when we're contracting our pelvic floor on the exhale, and the pelvic floor should be lifting up, we can just press a finger here and it should lift away, or a rolled up towel or a stability ball. And as we work into more proprioception and feeling of controlling our pelvic floor, you can see how the anus takes up a large portion in the opening there with the sphincter. So when we go into a posterior tilt, we can tilt our pelvis, but we can also try to close our anus. By contracting that sphincter, we can feel our pelvic floor a little bit better. And as we go into an anterior tilt, then we can go ahead and contract the clitoris or the penis if you're a guy, and you can feel the fibers and how they connect that way. So it's just a little bit more than just the tilting now and feeling the bones of the pelvis, but we also want to try to feel the musculature in there as well.